Welcome to T-BONE Speaks with Dr. Tarun Agarwal, where our goal is to change the way you practice dentistry by helping you achieve clinical, financial, and personal balance. Now, here's your host, T-BONE.
Everyone, to another week and another great episode of the T-BONE Speaks podcast. I want to thank all of you loyal listeners for listening in every week, and for our new listeners, I want to welcome you to the family. This is, quite frankly, probably one of my favorite episodes each month or every 6 weeks, however often we get to do them. I'd like to do them a little bit more, but it's called Ask T-BONE, where we answer common questions that we see being asked often or specific questions that are submitted to us. And this week, we're going to be talking about fixed hybrids and some common questions there. But as always, before we get into this week's episode, let's hear from our core and only sponsor, Meredith.
Hi, everyone. Welcome back. I have a few things today before we get started on this week's special episode. All of our episodes are special, but today's extra special. We have a review. So if you have not left us a review wherever you listen, preferably Apple or wherever, I think you can leave them now on Spotify and other places. This is from Drew Williamson. He's a student, and he said, "Hello, I'm a dental student in St. Louis in my last year and picked up listening to the podcast last October. Listening to this podcast is a great way to get real-life perspective about practicing and doing what you want to do post-dental school. As we all know, schools typically don't teach much business ideology while in school, and this is a great way to open students' eyes to what to expect following graduation and starting to practice. I wish I would have listened sooner."
That is so nice.
I mean, the good news is they're all recorded. You can go back and listen.
Yeah, I mean, you could have we should have
binge.
a Netflix.
Are you still watching? Are you still listening?
If we could get like
Are
a
you
Netflix
sure?
weekend of the T-BONE Speaks podcast, that would be so egotistically awesome.
Well, him talking about the business side and what they don't teach you in dental school, I think I just want to remind everyone that we do have a boot camp for case acceptance, bring your team, stay at the retreat, a great weekend filled with lots of things, breakout sessions. We typically recommend one person from the front, one person from the back, someone from the hygiene department. It's just
And the dentist.
A team.
Yeah.
You can't come without the dentist. It's just a great team bonding and way to grow your practice, I think. We have that coming up. We'll release the dates pretty soon, but please reach out to me if you're interested. You can call me at 855-332-2285 or Meredith at 3d-dentist.com.
Wonderful.
Yeah.
I'm excited about the boot camp. I think it'll be one of our more impactful programs because we've done the one-day case acceptances in the past, but this one will go into hands-on,
A little bit more in depth.
and it'll go into breakouts with our front office team member, our back office team members, so that way they can kind of work with our team. And then what we'll also be doing is adding in an advanced section where we talk more about segmenting and sequencing and dealing with more complex cases as well.
Yeah. Well, the real question is, since it's a boot camp, if you're going to lead a workout boot camp in the mornings.
I bought 12 yoga mats.
You did, and I put them away.
So that's your fault, not mine.
And I said, we are not messing with these right now. I'm saving them for the boot camp for you to teach the workout.
We'll do it in the backyard over the gumballs.
Okay, yeah, so they'll be gone by then.
Will
Sounds
they?
good. Yeah, summer, well, they'll be gone.
I don't know.
That's a fall thing. They fall
Okay.
in the fall, yeah.
Well, it's a spring right now.
All right,
so-
well, let's get into, that's because I haven't been cleaned up. Let's get into today's episode. So typically with the Ask T-BONE episodes, you guys submit questions pretty regularly, and then we go through and see what's interesting, what people ask most frequently. However, we posted on Instagram a few weeks ago, you doing a surgery, and we posted a few live things of it, doing an all-on-X type surgery. And there was a lot of questions. People were interested but hesitant.
Okay.
So we Michelle and I gathered a few questions.
It wasn't me because I was busy working.
Yeah, that we thought were interesting, that maybe you could answer for the peoples and
My
help.
subjects?
Yeah.
God, can I wear a crown now?
Yeah. So let's get started.
Okay.
Our first question was, you look like you've been doing this forever. So people were asking, when did you get started? Is it too late? When, in their journey, which I feel like it's never too late, they're asking, when was your first hybrid and what pushed you to do it?
Yeah, it's quite interesting you asked that because my first hybrid patient actually came in the other day with a broken tooth on the bottom. And it was a family member of a former team member, and it was not a great experience. So if I can remember, let me think
The
back.
whole surgery was not a great experience
The whole process.
Okay.
The whole process of my first
Yeah.
hybrid was not a great experience. I want to say that's probably 2011, 12, 10, 11,
Yeah.
11, 12, somewhere in that ballpark. I was looking to do a case. My hygienist at the time had a family member that needed a case. So two things collided. We did the case. I worked with my oral surgeon, and it was new for both of us. And I think through the process, we figured out very quickly that it was new for both of us. And what was interesting was putting the implants in was the easy part.
Right.
Getting them into the bone and all of that was pretty easy. Dealing with everything after that, which basically fell on me as the restorative dentist, that part was unbelievably complicated. It was complicated the fact that I hadn't done one before. The good news, the patient knew, team member knew, clearly the team member knew. But I learned so much from that. I mean, so much. And that one case is the reason that I searched out and looked for a guided way of doing this. And luckily there were concepts out there. We were able to work with some laboratories and help refine those concepts. But if I didn't find those guided ways of doing it, I don't think I would have ever done a case again, because the result wasn't as good as I wanted it to be. The result took way longer than it needed to take. And I'm not even sure that if I had even charged full fee, I'm not sure that I actually would have made any money. I'm pretty sure I would have lost money. So that also brings up to me kind of the process, because there are a lot of dentists out there. Let me back up for a second. I think there's a couple of ways I want people to think about how they attack hybrids. First is you don't have to do the surgery. Okay, I think the biggest barrier, looking back at myself, I believe the biggest barrier to getting into doing hybrids is this concept or belief that you have to do the surgery. The surgery is the daunting part.
Right.
Okay, it is a big surgery. I mean, there are bigger surgeries in dentistry, but that is a big surgery to do. And the surgery scared me. At that point in my career, I had been doing onesie, twosie implants. I was getting pretty darn comfortable with all of that, taking out teeth, doing some alveoplasty in certain areas, but I wasn't ready for hybrid surgery. But I knew I wanted to add that to my practice. I knew that from a revenue side, I wanted to do it. I knew that from a selfish growth side, that I knew that was the next step for me. So I looked for a partner, in this case, my oral surgeon, to do the surgery part for me. So I wasn't allowing not being able to do the surgery to hold me back from adding it to the office. Now, the one tip I would give to everybody that says, hey, I've got a great surgeon I can work with, is I took a conductor of the orchestra mentality to this. And what that means is I didn't just find the patient that was interested and then said, oh, let me refer you over here. I took a general contractor or conductor of the orchestra approach to it, meaning that I talked to them about the fees. I talked to them about how to pay for it. I talked to them about the whole process. I talked to them about everything. And then my surgeon was, quote unquote, a subcontractor who had his own fees, but we knew what the fees were, so we could kind of total it up and package it to the patient. And so that way I looked at that. That's what I mean by the conductor of the orchestra. I didn't send it over there and then hope the patient came back or hope the patient came back with what I was expecting. I took a more hands-on, more comprehensive approach to it with my surgeon.
So you worked the surgeon's fees into your
Yeah.
fee,
Yeah.
and had the patient just pay once, and you paid
Not
the
necessarily
surgeon?
patient pay once. That
They paid there. They just knew how much it was going
yeah.
to be
So
as part of the
it'd be
total
like,
fee.
it was the common issue we had from patients. They say, well, I paid him or
Right.
her. Now, why is this fee? So what I try to do, I'd be like, hey, Meredith, just to give you an idea, cases like this are in the $30,000 ballpark. That includes both parts of it, the surgical component and my component.
Yeah.
The surgical component is going to be roughly $10,000 to $12,000. My component is going to be roughly $15,000.
Okay.
Okay. And so you'll write a check to the surgeon for their part. You'll write a check to me for my part. Okay. Or we can look at funding, outside lending if you need that. And that way me and the surgeon will handle that directly. And so we I kind of gave them an idea of big picture, what it was look like. So it was not a great experience. Okay. But it was an important experience for me to have, because I wouldn't be where we're at today if I had never jumped into that. And I for sure wouldn't be where I'm at today if I had not partnered with the right-minded surgeon to help me get to these levels.
So then after sending patients to him, did you slowly start to go to these surgeries and start to do these surgeries on your own? Because being able, at this point, you're offering patients the full package and you're doing them. So that's giving patients, the ease of not having to run all over the place. So I understand where you started, and then how did you get to where you are now?
So I think it's a great question. I think certainly you've seen it, right? So I think it's a very easy question for you to ask, and it's a good question, by the way. But I always take a step back. I was very happy with the setup I had.
The way it was going.
The way it was going.
It wasn't broke.
It wasn't broke. You're right. It wasn't broke. Okay.
Yeah.
But it wasn't broke because I had a really good relationship with my surgeon.
Right.
So if Meredith came in as a patient and Meredith said to me, I can only afford $25K, I can't afford $30K. Me and the surgeon had an agreement that we split the loss. Okay.
Right.
I didn't necessarily I had to ask permission at some point. Okay.
Yeah.
But we had this working relationship over time.
Right.
To where I knew that, we're both in it to win it.
Right.
Right. And so that was that. Then I think the next part of that was I started to get occasionally a few patients says, why do I have to go all the way over to XY to Durham in this case, which is all the way is like 20 minutes. It's not that far. And I was like, well, I mean, you really don't want me doing
But you started
here.
to get patients from out of town.
Yeah, absolutely. We got
from
patients.
further and further away. So
And
you
out of
started
town
to
meaning not
attract,
flying in, but
Right.
like
Some?
1 or 2
No.
hours away. Yeah. And so when I started getting these questions from patients, this pushback,
Right.
they all went through. It wasn't affecting case acceptance that I was aware of.
Yeah.
But when I started getting this when I started getting more pushback as we were kind of getting far away, because part of the push is we tell patients it's a one-stop shop. We can
Right.
take care of you from beginning to end. And the way I sold, quote unquote, sold it to the patients was, we're going to go to the surgical center, which was my surgeon's office at the time, and we're going to do the case there, because your kind of work, it requires a bigger surgery. We need to have the equipment they have over there, and it wasn't an issue.
And this is when you started doing the surgeries.
Well, that's a little bit before that.
Okay.
Okay. But I'm just giving you what the patients wanted.
Right.
Okay. So what happened was I started hearing this feedback from patients. My sense is, how do I reduce the friction? So then I started saying to myself, at some point, I need to be able to do the surgeries here. Here meaning in my office.
In your office.
So I want to come back to that. Okay. But I want to kind of frame the story was I was very happy doing what I was doing. If it had continued like that forever, I probably would be happy.
Right.
Okay. Maybe happier than I am now, But my mind got open to something else because I was listening to patients. So it's no different than when your patients call and say, hey, do you have Friday appointments? And the answer is, at some point, if enough people ask, then you gotta succumb to the consumer. So anyway, so what was happening is these were big cases. We were all in, and then what would happen is I wanted to watch the cases.
Right.
So I would go over to the surgeon's office, and we would do these typically on Thursdays or Fridays. So, we've done a couple of cases on Saturdays. But again, I have a very unique relationship with my surgeon for this. And we would go over there and do the cases. And I would ask lots of questions, like, how does this feel? How does this work? Why are you doing this? Why are we doing that? And I learned and gathered so much. And we had such a good back and forth. I'm like, what if we tried this? What if we did this? Or what if we did that? And we would try it. And some of my ideas, many of my ideas were good ideas. Some of my ideas were not so good ideas. And then we continued to do it. And I watched. And at about a dozen cases in, I finally said, I think I'd like to try one of these. And Uday looked at me and says, yeah, no problem. Let's do it together. And I go, but I don't think I want to do one start to finish. I want to do each section one at a time. So to me, the first section is you got to lay the flap, which I think, and still to this day, it's probably the most daunting part of it for me.
Right.
Okay. And so we got a case once, and then he let me lay the flap. And then after I laid the flap, he says, okay, now let me finish up the flap because it wasn't big enough.
Let me redo that.
Yeah. No,
that
not
was a nice way of saying that.
Really, it was let me extend it so we could actually see what
Keep
we're
going.
doing.
Yeah.
And then we found another patient. So in the next case, he's like, all right, this time you do the bone reduction. And I did the bone reduction on that one and stuff. So, so we got a little bit better each time. And then I did the bone reduction. And then, then doing the implant part wasn't that complicated. So one of the next patients, I did the implant portion of it, and then the next case that we did, I did the prosthetic component of it. And so each, I had done a case over the course of a year, step by step by step, without really pushing my comfort zone, but also having a safety net.
Support, yeah.
It's a safety net.
Knowing that he was there.
Yeah, and it made it easy. It made it more comfortable for me.
Right.
And then slowly but surely, one day I said, "All right, I'm ready to do a case start to finish." He goes, "Great, I gotta go write my notes." so
You're like, wait. I thought you were gonna be here.
no, he was in the building,
Right.
but he's literally next door, just writing the notes. And slowly but surely, we just did it, and we did it, and did it, and it was like, "Oh yeah, I've done this part." And then I had to relax my fingers and my hands after laying that flap. It was so tiring to do it, and then reducing the bone, and then step by step we got there, right? And then it's amazing how we get to these points.
Yeah.
It's a confluence of events. Okay. So then Uday started a surgical center for dentists only. So then he's like, hey, we're not doing these cases at my office anymore. We're doing them at the surgical center. And then, so that limited my days.
And times.
Because I didn't have as much access to his place as I needed, right? So then we started going to the surgical center and doing the cases. But he was also out of his office and doing the work, so it became a little bit more problematic. So then one day, just happened chance, we were able to do a case side by side. So again, that was my first case all by myself, completely in a sense, but he happened to be there. So that way, if anything went wrong, we were able to do that. And then slowly but surely, it's just now I'm pretty comfortable doing probably about 50 to 60% of the hybrid cases that we see in the office. I'm comfortable doing about 60, maybe 70%, 2/3 to 3/4 of the cases that walk through. I'm pretty comfortable, but I still look at it that what is the best for the patient? And if I look at a patient and I say, God, if you were my sister or my mom, I would have my surgeon do this, then that's how we're going to do the case.
Or health issues.
Without question. The medical issues
probably what sends over half of the ones you don't do.
Right. It's a complex medical issue where the medical issue is somewhat controlled because of anesthesia, but it's the complications that occur afterwards.
Yeah.
I don't want to necessarily mess with those surgical complications. Egotistically, I think I'm capable.
Yeah.
But
it's not worth it.
Again, it's just about an abundance mentality. It's about I don't need every single case. Now, certainly, I want to control every case.
Yeah.
But that's kind of there. And then I didn't really touch on you. This is really a good question here.
Yeah.
I didn't touch on the guided portion of it. For me, some of the cases we did a couple of cases non-guided in the beginning, and they were okay, to say the best.
Yeah.
But they weren't as predictable as I like them restoratively. And then I've always leveraged technology. And then the first system I ran into was the InSequence system. A gentleman named Daniel Lopp was developing it, in charge of it at the time. And so we latched onto that, and we've since moved on to 2 or 3 different systems, and it really made my part easier. I remember in the beginning, my surgeon was always mentioning, "Man, this takes longer to do the surgery." I go, "But yeah, it takes me a third the time to do the restorative.
Right. It's worth it.
It's worth it to me." And I go,
Yeah.
and I wasn't being a jerk about this. I'm like, but it's worth it enough to me that if we don't do the surgery this way, I'm just not going to do the cases.
Right. I'm not interested.
And I think that was also eye-opening for him to understand
because
that
they're used to just doing the surgery.
they're just used to kind of doing what they want, right?
Yeah.
And I think also retrospectively, I think him learning the not guided surgery for me, but this guided process through me opened up for so many other his clients of his referral base.
Right.
Now he's able to offer something that basically he can do everything and send the patient back ready to be restored.
Right.
And even that part's just a matter of screwing something in.
Yeah.
So it's really been a win-win relationship for us.
So for those of you who are interested in adding this to your practice, we do have an All on X course, which teaches a guided workflow to make these cases more predictable. So back to what we were talking about.
I want to mention something about that, okay? There are a few things about hybrids that are definitely, I want people to understand. There's the diagnostic portion of it. That's, in other words, understanding which cases you should handle. Do they have enough bone? What we have to do in terms of setting up the teeth, because part of this process is you got to know where the teeth are going to be.
Right.
You got to know how long they're going to be, where they're going to be positioned, because all of that affects where you put the implants, what attachments you use onto the implants. Then there's the surgical portion of it, okay, which to me it's like Lego pieces. You just stack the things, you do it. There's the getting over the grossness of it, and then there's the restorative component of it, and that is taking the patient after they're restored and moving them through an efficient process to get their final restoration. And I think what we do very well is we merge all 3 of those disciplines. We merge the diagnostic component, the guided surgical component, and the semi-guided prosthetic component of it. And I think that's really what's nice. In other words, basically we're teaching what we're doing in the practice. It's not like we're making up stuff. This is literally exactly how we're doing it. Day to day, how are you leveraging CBCT, in-house planning, using laboratory planning for the final products, how we're taking digital impressions to make things a little bit easier, all of those things hands-on. I just wanted to make sure I mentioned.
Yeah.
I want to do a little bit of a sales pitch there.
Yeah. Well, there's one last thing kind of in your hybrid journey that I wanted to mention is you said that moving to the surgical center is kind of what pushed you to start doing these in your office. And as everyone saw on Instagram, your case the other week was in your office. So what gave you that next step, or what did you bring in to be able to offer it in your office versus the surgical center?
Yeah, so it's a great question. I think I always want to back up the questions, right? I want to go through the mindset. And to me, the mindset was no compromise, as convenient as possible. Okay, that's the goal. Okay, the goal is no compromise, as convenient as possible. So no compromise to me meant very well done work. Okay, very, very comfortable for the patient. Those were the kind of and as frictionless for the patient as possible. Okay, and what I mean by that is well done work means how good am I at doing this?
Right.
Is it an appropriate case for me to do?
Yeah.
Okay, so for me, there's very little compromise in that. If it's not right for me, we're going to refer. Okay, as comfortable for the patient for me refers to sedation. Okay, and I will get pushback from this. I will have people disagree, people that are doing a lot more cases than me. That I believe that all of these cases should be done with general anesthesia. Okay, we've done a few cases with IV sedation. They haven't gone as smoothly. They've turned out fine, but they haven't gone as smoothly. But our cases with general anesthesia is just less stressful for me. And that's what, working at my surgeon's office, he had an anesthesiologist on site. Working at the surgical center, they had an anesthesiologist obviously on site. So that's what I got exposed to,
Mm-hmm.
and that's what I said I needed. And then the frictionless part was patients didn't want to go a lot of places. They just
Right.
didn't want to run around, and that's the frictionless part of it. So the ultimate goal is to do these in office, right? So when appropriate.
Mm-hmm.
So I think what you're referring to is that we use general anesthesia in the office.
Mm-hmm.
And general anesthesia is tubing the patient, nasal intubation, so that we have complete control of the airway. They're using inhalation, they're using propofol, they're using all kinds of meds. Many of the things I'm not overly I'm not overly aware of exactly what these, how all of these work, ketamine, different things like
Yeah.
that. So we were at the surgeon's office, at the surgical center, and I still think there's advantages to going to the surgical center, quite frankly.
Mm-hmm. Because it's like a hospital type setting.
Yeah, we'll come back
Yeah.
to, because I do want to talk about that, because if I were giving complete choice, I would do all these cases at the surgical center.
Right.
But then having it in-house required finding an anesthesiologist.
Mm-hmm.
So there are dental anesthesiologists. We work with Dr. Braxton Henderson here in North Carolina. He does a phenomenal job. We've done probably 5 or 6 cases now with him that have turned out great. And so we're doing that. And I think that's super important to do. And so again, no compromise, comfortable for the patient, and a frictionless experience for the patient.
Yeah. Well, you talked about seeing your first cases and going to your surgeon's office and just how overwhelming it was and how much you had to learn. So imagine from the team's perspective.
Mm-hmm.
So I think people forget this type of procedure requires more work than just the assistants. It really starts at the front, from answering the phones to treatment planning to the labs, scheduling all of those appointments, and then the surgery.
Yeah. The surgery is the easiest part
I know.
of it.
I wanted to say that, but I didn't want to say it.
The surgery,
but the day of surgery is like, we've made it, right? Because there's so much prep work that goes into these cases that requires multiple people within the team. So how did you get them trained on how to talk about these cases, how to set these up, and how to do the surgeries?
You know, I don't know how to answer that, because I wouldn't say that I go about setting myself up to train people. I just think that I drag people to a certain degree. I mean, is that fair to say that I drag people along sometimes and some people fall off?
Well, yeah, some people wobble.
Right, but I think
But if people come to you, I think you do train them well.
Yeah,
But they have to put in the initiative, maybe. When you went to a course, did you take an assistant? I know that's an option.
Yeah, so
For the surgical part.
Yeah, I always believe that the first. Okay, so let
bringing
me.
in your rep.
Yeah, so let me back up for a second here. Okay, so somebody listening, you listening says, "Hey, yeah, you know what? I want to do these cases."
Right.
Okay. So the first and easiest step is you got to get some education, the capability to do these. Okay. I would love to think that 3D dentist is a great choice for this education, but there are many choices for this type of education. Okay. You got to get some education. Okay. You got to understand the systems, the parts and pieces, all of that stuff. But I want to push that to the side for a second, because I think it's the easiest thing to do, because this system, we're making it easy for you because we got courses that set you up for this. Okay.
Yeah.
I think the first step before that is, are you capable of selling these cases?
Right.
Okay. I think, to me, that is the number one question you got to ask yourself is, are you and is your practice capable of selling these cases? Do you have the patients?
Yeah.
Are they walking in and out of your practice? Do you have the capabilities for other dentists in your area to send them to you? Or do you need to do marketing to get these patients? And then part of that's also going to be,
how is your team talking to people?
yeah, is your team comfortable saying $30,000 or more?
Yeah.
Right? Or 20,000, whatever the number may be. You know, is your team comfortable with that part of it? Okay. And that's an important part of it. And for me, what was eye-opening in 2019 was I was spending a lot of money on external marketing through digital ad spend on Google, and our team was effing it up on the phone through no fault of their own, to be quite honest with you. It was my fault for for having certain people there and then having not trained them. We were answering the phone poorly. So there's a lot that goes into that part of it, okay? And I call that the case acceptance, the selling part of it. So to kind of get into your question, the role of your front office, okay, is to intake the calls, to understand the process, what's going on, so that when they call, they don't say, oh, we don't do all on fours, we do all on X's. Like, well, there's not really a difference there, right?
The patient doesn't know the difference.
Yeah, but they may respond to the marketing and say, oh, I want it all on four, or hey, I want Teeth Express.
No problem.
Right.
We'll figure it out when you come in for your consult.
Yeah.
We'll let you tell them how many implants they're going to
Right. So those kind of questions, and your front office team needs to know the cost of things, so that when people ask the questions, you can kind of a ballpark number, right? They got to know the process. This isn't
how long this takes.
Right, because they'll call and say, hey, I want that teeth in a day. And you don't want them to say, well, in our office, it's 6 months.
Right.
These are the things your front office needs to understand. They got to also understand how to sell your number one product. As we've talked about in the past, your number one product is people. And in this particular case, the number one product is the dentist.
Right.
They got to understand how to position the dentist as an expert to make the patient want to come in.
Yeah, and ask questions.
Yeah,
that's probably where you learn the most.
Absolutely. So I think there's got to be some homework done there. Now in our office we have treatment coordinators. We have Megan and Crystal, and so their job is to get the patient across the finish line.
Right.
Okay. So once the front office team hands the patient off to our quote unquote sales team, I know people hate the word, but that's ultimately what they do. They help get people across the finish line. So we bring the leads in through the front office. The front office transfers them to the sales team, the treatment coordinators. And our treatment coordinator's job is to contact the patient before they come in, to make sure they're scheduled properly and, kind of get prepared for them, to do the initial consultation, answer the most common questions. My treatment coordinator, Megan, in this particular case, is very adept at understanding how much bone we need, all of these things, a little bit talking about bone reduction.
She's also a hygienist.
Yeah.
For people who don't know.
So
she's not front office, just looking at the bone.
Yeah. So she's comfortable with that. But my argument back on that, Meredith, is
you can teach that.
Hygiene skills didn't teach her that.
Right.
That was.
I just mean she has some clinical experience.
So that was just going through the process, right? Multiple times. And then so her job is to then bring me in. I kind of do whatever little bit I do, which is basically try not to screw it up.
Yeah.
Okay. Answer any questions. Say, yeah, maybe I don't want to touch this case, or hey, this is a great case. I kind of give Megan a red light, yellow light, green light case, and that means like a green light case means like this is a case I can do. This is a case I can be flexible on financially.
Right.
A yellow light case is, hey, this is a case I can do, but this is a case we have very little financial flexibility. A red light case means it's a case I don't want to do, and this is a case where I need to get more than my normal fee because of the complications of the patient expectations and the overall complications of the work, scope of work.
Right.
So we get her through that, and then Megan's job is to work the patient through the finish line, okay? And sometimes, like the case we did recently, that patient said yes the next day. Sometimes those patients, on average, 6 months
to a year,
6 months to a year is because it's a big commitment for them. So her job is to stay in touch, to quote unquote work the patient, and by that means we're not trying to convince them. Or we're the patient advocates.
Yeah, we're here for you whenever you're ready.
Yeah, we haven't forgotten about you. Because a lot of times patients feel if they don't say yes right away, they feel a little bit of embarrassment to call back and ask.
Yeah.
So we prefer to kind of contact them. And then Megan, and I think this part is unique to how I've set it up, and I think it's also unique to Megan's personality. Megan will be there day of surgery. She will take care of the pre-op. She will take care of the post-ops. She will be the liaison of patients calling me. So in other words, patients call her. Right. She kind of processes it and then calls me if I'm needed to take care of these things. And then Megan's job is the finish line for Megan is kind of getting them through the day of surgery. And then what happens after they get through the day of surgery is they're now in the assistant team. And now my assistant is managing that patient in the sense of the lab work, the 3 or 4 appointments it takes to get to final, and all of those things. And then in our particular case, since Megan is the hygienist, they circle back around to Megan for our recall, for the recall program for them. So, it's kind of unique, I guess, in our situation, but that's kind of the process. And along the way, I would argue the area that I've given the least attention to is the front office. I need to spend more time training them and doing them, and I think it'll help us do more cases.
I agree.
I think we've done a great job with the rapport we have with Megan, and as we're developing it with Crystal, to build that. And I think the assistant part has just it kind of happens. I don't think I've ever sat down and said, "Here's what a hybrid does," and all of this. I think it's just doing it, watching it. So I'll back up. I will give myself some credit. I did make the assistants go with me to the surgical center when our surgeon was doing the cases. I would have them go with me so they could watch, and I would say, "Hey, do you think we can do this?"
Yeah.
Or I wouldn't say it that way. I would say, "Hey, we're going to start doing this."
Yeah.
Because if we do, you think we can do it? I would hate for them to say no.
Yeah.
So So I guess to a certain sense, I have trained people, but I've never really done it in a formal sense. We've just kind of done it step by step, and that's what I refer to as a success path. And so many of the things I talk about, you got to train people step by step.
Yeah.
Did I answer that question?
Yeah.
Okay.
I think that was really good. I mean, and I also want to add, you're bringing in your rep.
Yeah.
For these types of
Absolutely.
cases.
Yeah.
So that's an additional person in the room that can, this case is not just you and the assistant in the room. So the other week you had the anesthesiologist, you, 2 assistants, a main assistant, a backup assistant to hand off to her, and then also a rep, which could act in turn as like a third assistant to grab you anything. They're familiar with all the parts and pieces. Yeah. They were there to help train the second assistant. Yep. I think that's pretty important if you're able to, and that's kind of the value of a rep. Yeah,
look, at the end of the day, we've been very fortunate. We have a lot of loyalty to BioHorizons. They've been very good to us at 3D Dentists. Yeah. They've been very good for us in the practice. I pay for everything as much as I would like not to, but I do pay for everything. But the rep's value there is efficiency for me. It's just one more knowledgeable hand. Yeah. To get things done. Because at this point, let's be frank here. At this point for me, the rep's not helping me necessarily learn how to do the procedure. She's now there supporting my team, getting my team ready, understanding. And to Aubrey's credit yesterday, she's like, "Hey, we have a new product that is specifically designed." I don't know if you saw those comfort caps that they developed. And I was like, "Okay." She's like, "Great, I'll make sure I order these for you so that you can have them for the next class." Yeah. Or, "Hey, I noticed that you're using this. Let's move you to this product. I found from other surgeries that I've been a part of that this particular mallet or handle, whatever it is, it works out a little bit better."
What other people think about it. They're seeing other surgeries too.
So I think
take that feedback. I think a lot of people
take advantage of it. And if your rep's unwilling to come to your surgeries, bump them, move on, find another rep or another company even. And I say that dead seriously because you're paying a premium. Right. So you deserve premium service. If you're ordering an implant every once in a while, you don't deserve as much service as someone like me that's ordering implants pretty regularly. And I don't deserve the service that my surgeons get because they're ordering implants way more often than me. Right. So that's part of capitalism, part of business. But Megan schedules with the rep as soon as the patient says yes. We in our case, we have to coordinate either the surgical center or the anesthesiologist. So we know the date, a couple of months in advance, a month in advance. The rep is known right away. As long as the rep, almost 90% of the time, Aubrey's able to adjust her schedule to make it happen. She pops in for 3 hours and it's good. Yeah.
Well, talking about the rep and BioHorizons and some of the things you're using, what type of technology and guides and processes of this have become a game changer for you as you've grown?
I'm always going to come back to the number one technology is always cameras. Okay. Cameras help sell the case. Okay. It helps people see what we've done new and unique now. I don't want to say unique. What we've done, what's new for us in the last year or two and regular is that we're doing facial imaging on our patients. And by that, I mean simulations. Right. We're taking a nice face and we're doing a DSD simulation, or we're in our case, we're partnering with a lab to do it for us. And that way it's one more part of the selling. Right. And so the photography is the number one technology. Yeah. Okay. Then the second part of the technology is going to be, you got to have CBCT to do these cases. Ideally, you want to have digital impressions. All the stone models work because the laboratory can convert them. But I think you need cone beam and I think you need digital impressions.
Right.
to be able to really step up the technology game. And then there's a plethora of guided systems out there. Now, certainly
Yeah.
I have my preference on these, but I've used 4 systems and they've all been very good.
Right.
So there's no, I don't necessarily want to say that one is better than the other.
Yeah.
They each have their pluses and minuses.
Right.
Okay. And then when it comes to ancillary things, the ISQ is nice to make sure we can load it, to have that confidence that we can load it. The BioHorizons, I think the Tapered Pro allowed me to switch to them for my full arch cases because I didn't feel that the tapered internal implant was aggressive enough
Right.
to get the stability I needed. So that allowed that particular move on their part allowed me to step into these types of cases with them. Then having the right tools at the right, for the right job at the right time. The development of our 3D dentist surgical kit from TBS, that's been great. Developing, I don't know if you noticed this yet, Meredith, yesterday or the other day, is I got one burr block now.
Right.
That takes care of the bone reduction. That takes, all the little things like Meisinger work. So nice to work with me. Yeah, I guess they're using me to a certain degree too, right?
But we've made a 3D kit that kind of
so,
has everything that 90% of what you needed.
Yeah. So and it was there, and then we didn't use it yesterday, but we have the Acteon piezo. If we had to do a sinus lift, or if we had gentle bone reduction, then yesterday wasn't so gentle.
Yeah.
But and then the right motor. Even having motors that have the appropriate amount of torques, having the right biologics to be able to do all that. I think there's so many parts and pieces and things that go into it. Sometimes I forget because I'm not just jumping into that. I traveled a road to get here. And I believe that's the best way to do it. I don't think that all our next cases should be done by people that are new to implant dentistry. It's just my personal opinion. Are they capable of putting the implants in? Absolutely.
Yeah.
Okay.
Right.
But it's all the stuff beforehand, all the stuff afterwards. But we have to start somewhere.
Yeah.
Okay. So I started somewhere. I made my mistakes. I don't regret it at all. I'm so happy that my first case was a disaster.
Yeah.
Okay. I'm so happy.
And that you kept going because you could have been like, I'm not going to do this anymore.
But I think that's one of my gifts in life is that I'm just stubborn and keep pushing at it. Although I have given up on infant frenectomies and TMD. I'm not interested in those two things.
Yeah. Yeah. I liked the infant frenectomy.
I know you did, but I didn't.
I know.
So I was out.
Okay. So we talked about how your journey went, how you trained your team, what technology makes this better. And I think overall we've realized, and I think sometimes you forget because this part goes so smoothly in your office, is the organization. Like you said, the pre-work, the post-work, all the parts and pieces. I mean, literally organization of parts and pieces and then organization of the patient, the labs, and all the people. What do you think could have gone better?
Well, I think my ring light could have worked all day yesterday during surgery. That would have been nice.
By the way, I was the recorder, okay? I just want you guys to know.
I had to throw that in there. I did ask you if you're comfortable watching the surgery, But,
I know. I worked. Yeah, I've seen them. I've worked. I've never assisted, but I've seen them.
But
you never called in the C squad for
no, I
surgeries.
didn't. Clearly, we were beyond tissue punches, so I definitely didn't need to get to the D squad either on this one.
Oh, so Michelle, you're the D squad. I think I at least made the C squad.
No.
You asked me if I was okay with the blood and the surgery, and I was like, yeah, I'm fine. And then later I told you the worst part was watching him set it up for the sedation. Like, I can do the teeth and the surgery all day. The eyeballs and the nose, I do not like.
Yeah, I know. I think what could have been better. Yesterday's case, I think we could have been. I felt it took a little too long. Okay, but
I don't want people to think you have to rush, but you do have people under sedation, so you don't want to keep them.
Yeah.
Under for no, we also were walking through things a little bit.
So here's what I could say could be better. We could have been at the surgical center yesterday. And here's why. I saw people walk by and I saw Whitney or somebody shake their head at them because I knew people wanted to come in and ask me questions. And I'm very grateful to you, Whitney, whoever else in the room for not allowing that to happen. But to me, there's a couple of things why I like to go to the surgical center. One, I transfer
You're
liability.
unavailable.
Well, I transfer liability completely to them. That is
Correct. Yeah.
because ultimately, even with the anesthesiologist, there's some liability on my end. Okay, so when I can go to the surgical center, I transfer that out to the surgical center.
Yeah.
Which to me is huge. But I'm not available. Right. I literally, like yesterday, I ended up seeing 4 patients afterwards.
I know.
Right. I mean, and look, I'm not saying, oh my God, I can't do more than that. But there was a part of it where I was like, oh, good, I guess I could see a few patients. Not that I would want to schedule them, but I think if I had gone to the surgical center, I would have never come back to the office.
Right. That's like we said, this starts as event dentistry. And when you're out of the office, it's still kind of event dentistry. And then you're done for the day.
Yeah. Like literally our protocol has been go there, do the work. We eat lunch at Outback.
God, you can't go anywhere better than Outback.
Well,
is this a tradition?
It's a tradition now. So during COVID, not every place was open. So Outback was open. So we've done it 3 times actually. We went to Outback for lunch, and then we all dispersed and went about our lives. And it made it in a way a day that we all look forward to. Okay, because it was an easier, I know dentistry wise it's not necessarily easier, but it was a mentally less
chaotic.
You're
not running around chasing each other. You have one patient.
Well, you know what else could have been better yesterday? The dichotomy of what I did on a couple of patients yesterday. In the morning, I took out 16 teeth, reduced 4 millimeters of bone, sunk in 6 implants, put a conversion prosthetic on somebody.
And you took out the lower teeth.
And I took out a few lower teeth, not all of them, just a few. I took out a few lower teeth. And then like 2 hours later, I'm prepping a veneer on a patient, which is the absolute opposite in terms of fineness and motor skills.
Right.
And it really helped me
You're
see.
Like chisel? Should I chisel this veneer off?
Should I get my Peter K. Thomas instruments out?
Close your eyes. This might hurt.
And it helped me realize more and more why, as general dentists, we need to have days of certain types of dentistry. I think I mentioned it on a previous podcast where you have to have surgery days, non-surgery days.
Yeah.
And there's a reason, because yesterday I wasn't bothered until I think 11:30. I was finally done, like the patient was dismissed or whatever. And then after that, I started getting bothered, and it was, well, we got
Can you see patient at 1?
Well, we got a veneer that broke off, a crown that broke off on, a veneer that broke off on number 9. Can you see the patient? Because if you don't do it today, you can't see them for a month and a half, and nobody wants to walk around without a tooth. And I said, okay. And then it was like, well, we got a consult coming in.
And then she was 30 minutes late.
And then we got a consult coming in, and then I went and did a hygiene check, and then I did something else, and I was like, God. And imagine doing that, the mental stress, and I don't think you guys or the team members understand the mental stress of changing your mind from I'm ripping people's teeth out to, hey, how you doing on hygiene check today?
Yeah.
I think what it takes to switch modes and to do that multiple times per hour is just so exhausting. And I think there's got to be a better way.
Yeah.
And so I look forward to these surgery days. I think, I don't know. Are there any other questions on this?
The way you said blocking out days for surgery, I think that takes block scheduling one step further when you're literally blocking days for certain types of cases instead of just blocks and a couple hours here and there. You're actually starting to block days. And I think that's a big deal.
Yeah, and in this particular case, especially with the anesthesiologist, I mean, he's booked out farther than I'm booked out.
Right.
So,
and he charges by the hour, so you have to be
I have to be on it, right?
Got to figure that out.
I'm trying to figure out if he charges by the minute sometimes. So sometimes I'm sitting there talking to him, and it goes through my head like, is he charging me?
Wrap it up.
Wrap it up. So yeah, it's a phenomenal procedure. It is probably the most life-changing procedure we do in our practice. Probably one of the most life-changing procedures we do in dentistry. And we are taking people that are debilitated, either with no teeth or effectively no teeth.
Right.
And we're giving them an opportunity to step back into social society. And to be confident, to be able to function and chew, and to really help move their life forward. And that's not lost on me. And so I encourage every surgically oriented dentist to get into doing these yourself, pick and choose.
Yeah.
I encourage every big case oriented dentist, if you're doing full mouth rehabs and you're doing cosmetic cases, you've got the skills to sell and restore these cases. And now it's just a matter of learning how how our guided process works, and then plugging in the surgeon that can do the surgery part.
Yeah.
And I encourage people to do that, because it's life-changing work. I felt like a hero yesterday, a little bit, that it went without a hitch, and that we were able to do it.
And she was under 30.
Yeah.
So she has a long life to live.
And unfortunately, probably she's
teeth.
going to have this redone at some point in her life. So, and that's where zygomas, which I'm not going to do. But I said I wasn't going to do these surgeries either. So.
Right, and look where we are.
But I think I'm going to draw the line at I'm going to let other people do the zygomas.
Okay.
So, anything else, Meredith?
Yeah, our last thing, if you had one piece of advice for people who are wanting to get into this that you wish you knew when you were just getting into this, what would it be?
I wish somebody, I wish I could have seen something from beginning to end. Like, I wish, because I have that personality that'll fight through the pain and the learning curves and stuff. And a lot of people don't.
Yeah.
And I think I wish somebody had shown me the way, the possibilities of what technology does for a procedure like this. And because I would have jumped on it quicker, and I would have jumped into it deeper than I have. And I think that's a lot of it is what our course does, what YouTube has done.
Yeah.
There's no shortage of place to see what's possible. The labs will come in because they have invested in. They'll show you what's possible.
Right.
But there are benefits to courses run by practicing dentists or professional course providers
who are doing this type of surgery.
Yeah, because there's nuances. There's nuances on the lab sees their side.
Right.
The reps see their side. As dentists, the surgeons see their side.
Yeah.
Now, as the general dentist, I'm all those things. I am the patient manager. I am the lab manager. I am the rep manager. I am the surgical side manager. I am the restorative side manager. I'm all of those things. And I think, you can learn its and bits everywhere, but, being able to put it all together would have been really nice for me. And I think that's it. And the other piece of advice, I'm sorry, I should probably said this first, is train your front office team on how to handle the phone for these cases. It costs too much to acquire these patients. They're not far and few between, but they're far and few between that you really need to work with these patients. And I think the bottleneck in our practice is the front office team getting more comfortable answering these questions and working with them to make that happen.
Yeah, and appreciate the front office team when they do
Yeah.
convert a patient.
They get the least love in the office.
They do.
Yeah.
And I remember Megan used to say to me, they would mention they talked to you on the phone before they came in. They were impressed. That's either where you win the patient over or you lose them from the beginning. So, well, hopefully everyone got a lot out of that and is looking, by the time they listen to the next episode, will be looking to implement this into their practice.
Yeah, I hope so. Listen, don't look back. Worst case scenario, you spend a little bit of money, you see a procedure you don't like, and you just, at least in your mind, you don't like to do it. But everybody, thank you for listening. Leave the reviews. If you could do me a favor, if you search 3D Dentists on Google, we're trying to bump up our Google reviews so that we can rank better on SEO. The podcast reviews are great, but 3D Dentist reviews on Google would be even better. Thank you, and I'll see you guys next week.
Thanks so much for listening to T-Bone Speaks with Dr. Tarun Agarwal. Remember to keep striving for excellence, and we'll catch you on the next episode.